Good afternoon. I'm going to talk about the medical management for liver abscess, but the general approach to a child who has a liver abscess, number one is for us to have a high index of suspicion because like we've seen already, most times the clinical presentations are not like specific for liver abscesses. And then when you have a high index of suspicion and you have taken your history and clinical examination, then you can do all those imaging studies. And then it's followed by a blood culture and then the culture of the aspirate, which will eventually guide our antibiotic therapy. And then the serum, IgG, IgM analyzer for entomoeba histolytica. And then when you have done that, you should not delay starting antibiotics. We start on an empirical antibiotic and then we adjust following the culture results. So those are the modalities of management. In the medical aspect, we use antibiotics, but there is surgical and then the radiological, which Dr. Maxwell is going to talk about. The antibiotics, we should start an empiric broad spectrum, but it should be parenteral antibiotics, and it should be given depending on the gram stain and then culture results. But yeah, and usually the therapeutic regimen should be revisited once the culture and sensitivity results are available. And when you do your cultures and they've recovered more than one organism, this should suggest polymicrobial infection. And your treatment should be inclusive of anaerobic coverage. Yeah. So the options we can use a third generation cephalosporin plus clindamycin or plus metronidazole. Or we can use a broad spectrum penicillin with an aminoglycoside. Or in the instances you don't have a third generation cephalosporin, you can use a second generation cephalosporin. So in some instances, we can use monotherapy using a broad spectrum antibiotic, but with that contains a beta-lactam inhibitor, like piperacillin with tazobactam, or ticagrelin with clavulanate. And or the other option would be to use ceftriaxone, for example, plus metronidazole, or ciprofloxacin or levofloxacin. But you make sure you add metronidazole for the anaerobic coverage. In the case of entomoeba histolytica infection, which is a common cause of liver abscesses, and if it's not very complicated, it can be managed conservatively. But most times where there is pus, you need to let it out because the antibiotic penetration to where pus is, it's not good enough, it's not very good. So for histolytica, we need to first use a tissue amebicide to eradicate the invasive forms of the trophozoites in the liver, including those that are in the intestinal walls. Then after that, you give something that clears the asymptomatic colonization, those that are in the lumen of the GIT. So, the ideal amebicide should be able to act within I've already said that, within the intestinal lumen, the wall, and also systemically in the liver parenchyma. And there are a number of options. Emetin is it's called, I think, a derivative of ipecacuanha. Yes, it's a kind of alkaloid. It's good, although it has many side effects, so most physicians are hesitant to use it. And that dihydroemetin is another form of emetin. But chloroquine diphosphate is also good, but it's only limited to the liver parenchyma only. It doesn't have good activity in those trophozoites that are in the lumen. And metronidazole and tinidazole. And we've seen that metronidazole actually for entomoeba histolytica is the drug of choice. But the option can be tinidazole, which is also, it's in the same class of nitroimidazoles as metronidazole, and they are closely related. And the advantage with tinidazole is that it's well tolerated by patients, and it has a once-a-day dosing. So it may be better than metronidazole in some cases. But we have metronidazole more available for our populations. Yeah. I came across for the luminotrophozoites of E. Entomoeba histolytica, you can add medications like paramomycin. It's able to clear those that are in the lumen, which have not been probably cleared by the metronidazole in the liver. Yeah, and there are others like diloxanide, furet. Yeah, so that's the medical management. The prognosis. If left untreated, usually pyogenic liver abscesses, especially those caused by staph aureus, like we've seen already, they can be associated with very high mortality. There are literatures that have said up to 100%. But when you start, when you make an early diagnosis and you start appropriate treatment with drainage and then long-term antibiotics, it improves the survival. The mortality reduces to about 12 to 15%. With Entomoeba histolytica, usually when you start drug therapy, the improvement is actually quite very dramatic. They recover, like usually within a week you can see clinical improvement in these children. And within a week you can see clinical improvement, but the treatment, the therapy is usually, it should be prolonged. The literature says about 4 to 6 weeks. We have to continue antibiotics for that duration of period. And much as there may be clinical resolution within that period of time, the radiological resolution may take longer to appear. So that may be able to explain what we've seen in our child. Like after a month of treatment, there are still radiological features when they did a repeat scan. Yeah. And for amoebic abscesses, death usually occurs in 5% of patients with amoebic liver abscesses. And this death is usually due to when the abscess ruptures into the peritoneal cavity, it causes peritonitis and bad septicemia. And also when it ruptures in the pericardium. And usually these are the abscesses that are on the left lobe of the liver are the ones that are most likely to rupture into the pericardium. Yeah, those are the poor prognostic factors. If a patient has multiple, okay, maybe there's more than 70 years may not apply to us in the pediatrics, but those who have multiple abscesses tend to have a poorer prognosis. Those who have infected with more than one organism, they also have poorer prognosis. And then those with the presence of maybe a hepatic malignancy or another malignancy, and then they get a liver abscess, they tend to have a poorer prognosis. And those who are immunosuppressed from one condition or another, and if there is evidence of septicemia. So the complications of liver abscess, they can be pleuropulmonary infection, which is the most common complication, and I think that's why you talked about a chest X-ray. There may be a right-sided pleural effusion, but it can also occur from the rupture of the abscess into the chest cavity and can cause an empyema. And hematogenous spread can also take the infection into the parenchyma of the liver. Bronchopleural fistulas may occur, but they say it's on rare occasions. And when a bronchopleural fistula occurs, they say patients may expectorate something that looks like anchovy paste. I've not seen it before. I've seen it in pictures. It's, I think, something brownish. Yeah, like brownness. Yeah. And when you do a sputum analysis of this, what is expectorated, you may be actually able to demonstrate trophozoites in the sputum. Yeah, cardiac involvement can occur, but, like I said already, from rupture of abscesses that are in the left lobe of the liver, and it's associated with high mortality. And then also intraperitoneal rupture, which occurs in 2 to 7% of patients with especially entomoeba histolytica liver abscesses. And it's usually mostly because in those with the left lobe abscess, because their presentation may not be so overt, and their diagnosis takes longer. Yeah, and they present later. So still rupture can occur in the peritoneal organs like the stomach, into the mediastinum, and there are others that have been associated with hepatic artery aneurysm. The artery gets enlarged. Thank you.